Today I will discuss on essential hypertension and anesthetic considerations. Essential hypertension is a common problem and defined as the BP more than or equal to 140 mm mercury systolic or diastolic BP is more than equal to 90 mm mercury. Of these, 63% are aware of their hypertension, 45% are receiving treatment, and only 34% are under control using a threshold of 40 by 90 mm of mercury. Proper perioperative management is essential in anesthetic practice. General principles. Definitions. Essential hypertension, no secondary cause for hypertension can be described, such as pheochromocytoma, hyperaldosteronism, Cushing syndrome, neurovascular hypertension, or active aortic coarctation. Essential hypertension comprises 95% of all cases of hypertension. Classification. Risk factors, complications, uncontrolled hypertension defined as systolic BP more than 180 millimeter of mercury, or diastolic BP is more than 110 millimeter of mercury. Classification of hypertension. BP classification, systolic BP and diastolic. Normal systolic is less than 120, diastolic is less than 80. Pre-hypertension, that is 122 to 139 millimeter of mercury systolic, and diastolic is 80 to 89 millimeter mercury. Stage 1 hypertension, systolic is 140 to 159 millimeter of mercury, and diastolic is 90 to 99. And stage 2 hypertension is 160 to 179 systolic. Diastolic is 100 to 109. Stage 3 hypertension, systolic is 180 to 209 and diastolic is 110 to 119. And stage 4 hypertension, the systolic more than or equal to 210 and diastolic is more than or equal to 120. Risk factors for essential hypertension. Increased age, genetic or family history, and obesity. Excessive dietary sodium intake. Alcohol consumption of more than equal to 2 drinks per day. Tobacco use. Stress. Perioperative considerations for uncontrolled hypertension. Delay the elective surgery in case of uncontrolled hypertension or existing target organ damage that can be improved or should be evaluated further. Increase or modify the antihypertensive therapy. Consider adding beta-adrenergic antagonist. For emergency surgery, consider invasive monitoring of perioperative hemodynamic, that is arterial line, central line. Risk factor for essential hypertension, that is increased age or genetic or family history, and obesity. Excessive dietary sodium intake, alcohol consumption of more than 2 drinks per day, and tobacco use and stress. Perioperative considerations for uncontrolled hypertension. Delay the elective surgery in case of uncontrolled hypertension or existing target organ damage that can be improved on or should be evaluated further. Number 2, increase or modify the antihypertensive therapy, considering adding the beta-adrenergic antagonist. For emergency surgery, consider invasive monitoring of perioperative hemodynamics, that is arterial line and central line. End organ damage, cardiovascular, like coronary heart disease, then cerebral vascular disease, transient ischemic attacks or ischemic strokes. Peripheral vascular disease and left ventricular hypertrophy, congestive heart failure, retinopathy, kidney failure, neurologic, that is hemorrhagic stroke or hypertensive encephalopathy. Perioperative consideration for patients with end organ damage. Detailed preoperative assessment with a focus on end organ damage should be performed in any patient with essential hypertension. Appropriate referrals should be made and the patient's medical conditions optimized prior to surgery. Treatment and management, that is lifestyle changes, weight loss, moderate alcohol consumption, smoking cessation, reduced sodium intake. Pharmacology, ACE inhibitors, beta-adrenergic antagonists, thiazide diuretics, calcium channel blockers, angiotensin receptor blockers. Anesthetic management of the patient with hypertension. Preoperative evaluation. Assess the patient's baseline BP and self-management at home to identify possible shift in the cerebral autoregulation. Patients with untreated severe hypertension have a higher incidence of stroke, myocardial ischemia, and kidney failure because of chronic changes in the autoregulation of end organ perfusion. No clear consensus exists regarding the timing of elective surgery in patients with uncontrolled hypertension. However, recommendations according to hypertension stages are as follows. Stage 1 and 2 hypertension. Proceed with anesthesia and surgery. Stage 3 hypertension. Consider postponing the anesthesia and surgery, especially in patients with other cardiovascular risk factors like end organ damage. Stage 4 hypertension, that is, defer the anesthesia and surgery whenever possible. Begin appropriate antihypertensive therapy and arrange for follow-up or inpatient BP control. We come to the end of this part, and the next part will be taken up in the next lecture.